Assalamu alaikum. Today we will discuss another very important aspect of endometriosis, which I discussed in my previous lecture as well. This is endometriosis and infertility. So this is a very common aspect which is related to endometriosis. Whenever a female patient comes with complaint of endometriosis and she has the diagnosis in endometriosis, and infertility is associated with it whenever a married female comes, because it is associated with deep dyspareunia, which mostly results in infertility, as well as all the adhesions and all the havoc that endometriosis make in the abdominal cavity. All is related to infertility. So starting with today's lecture, we will be discussing recommendations which are presented in Asia guidelines, and after that we will discuss the final outcome of all the recommendations. So this is regarding the medical treatment of endometriosis associated infertility, that what medical treatment or what ovulation induction drugs are recommended to use in infertility that is because of endometriosis. Okay, so we will talk about ovarian suppression. What is this? To suppress the menstrual cycle, to suppress the periods. Is it recommended in endometriosis or not? So the drugs that are commonly used for ovarian suppression are danazol, OCPs, GnRH analogs, that is available by name of Zoladex, Pramlid N, that is the progesterone only drug. So all the drugs are used for ovarian suppression, but are these drugs recommended in endometriosis associated infertility or not? So the answer is clinicians should not prescribe ovarian suppression treatment to improve fertility. What is the basic concept? These drugs can be prescribed to treat the pain that is associated with endometriosis, because if menstrual cycle is suppressed or delayed, then the release of ova or egg or ovulation, it is also suppressed. So when ovulation is suppressed, the menstrual cycle is suppressed, estrogen progesterone remains at a plateau level in the body, then endometriosis, wherever it is present in the body, it will not cause pain, because the pain occurs during the cycle mostly. However, the deep endometriosis, its pain can be associated or can be present on other days of the cycle as well. It is not just confined to the days of periods, but that pain, which is dysmenorrhea, it is only present during the cycles. So the cycles are suppressed whenever the patient complains of pain. But if a woman comes with complaint of infertility, she should not be prescribed ovarian suppression drugs. Clinicians should not prescribe hormonal suppression after surgery to those females who are anxious to conceive. So this is another very important point, that if a woman, she has been operated for endometriosis, like whatever surgery she has gone through, ablation, excision, diathermy, whatever, will she be taking hormonal suppression drugs? Are these drugs necessary? So the answer is no. If she wants to conceive, then these drugs should not be prescribed to her. But if an unmarried girl, she has been operated for endometriosis, and she can be prescribed ovarian suppression drugs to delay or postpone her cycles, because her major complaint would be pain, not, she would not be anxious to conceive. Those females who cannot decide to conceive immediately after surgery may be offered hormone therapy, as it does not negatively impact their fertility and improves immediate outcome of surgery for pain. So the important point is, there would be few females who are not anxious to conceive, no matter they are married, but they would not want to conceive and they want to delay their pregnancy. They can be prescribed hormonal therapies, because it will affect their pain after surgery, which will be reduced, and it does not negatively impact the fertility. Anti-inflammatory drugs such as pentoxifylline and aromatase inhibitors, letrozole, are not recommended outside ovulation induction to improve natural pregnancy rates. So this is the recommendation that is written in the guidelines, that letrozole or whatever drugs, some clinicians, they prescribe these drugs continuously to inhibit ovulation, because the continuous prescription of these drugs can delay or inhibit ovulation. So this is not recommended to improve natural pregnancy rates. Okay, Surgery for endometriosis associated infertility. Operative laparoscopy could be offered as treatment option for endometriosis associated infertility in stage 1 and 2 endometriosis as it improves rate of ongoing pregnancy. So yes, operative laparoscopy it could be offered as a treatment option for endometriosis associated infertility if a female presents with stage 1 and 2. Diagnostic laparoscopy and therapeutic laparoscopy, they can be done at the same time. No data obtained from surgery of endometrioma associated infertility, but it may increase chance of fertility. So if a surgery is being performed for ovarian endometriomas, they have to be removed. They can be removed, but no data has been obtained that whether their removal can have a positive impact on the fertility outcome of a female or not, but it may increase the chance of fertility. No compelling evidence exists that operative laparoscopy improves fertility rates in deep endometriosis, but it improves symptom in patients wishing to conceive. So all the thing is about the symptoms. If a patient has symptoms of pain and she is unable to live a happy life because of pain, and she is being operated to relieve her pain, so it might improve her fertility symptoms as well, chances of fertility as well, because her pain will be reduced. Okay, the decision to perform surgery depends on patient symptomatology, history of previous surgeries, ovarian reserve, and estimated endometriosis fertility index. So this we discussed in our first lecture, so you can refer to my first lecture to understand what is this endometriosis fertility index. So a surgery has to be done or not, it is dependent on the patient's symptomatology. What are the symptoms? Has she had any previous surgeries? What is her ovarian reserve? This you can calculate by having testing her follicle stimulating hormone and anti-Mullerian hormone and her estimated endometriosis fertility index. Other factors such as endometrioma size, bilateral endometriosis, adenomyosis, and other factors affecting fertility should also be evaluated. So these other factors, they include the male factor or any other family history of infertility. So all of these things, they should be evaluated before performing a surgery on a patient with endometriosis. Okay, so what are the recommendations for artificial reproductive techniques in endometriosis? Tubal function is compromised, diagnosed by hysterosalpingography or laparoscopy. So when are you going to do artificial reproductive techniques that includes IVF, ICSI, intrauterine insemination? They are advised to be done when there is diagnosed defective tubal function, which is diagnosed by hystero or laparoscopy. If there is confirmed and proved male factor infertility, if there is low endometriosis, yeah, estimated fertility index, other treatments have failed. So these are the 4 recommendations for which ART is recommended to be performed in a patient with a woman with endometriosis. ART after surgery. So if a female has been operated for endometriosis, does she need ART or not? For use of ART after surgery, endometriosis fertility index should be used as it is validated and cost effective. Again the same thing, EFI has to be used. Partner semen analysis should also be taken into account. This is a very important thing which has to be kept in mind. Stage 1 to 2 endometriosis associated infertility. If there is stage 1 or 2 endometriosis, then intrauterine insemination with ovarian stimulation, it is recommended. For ovarian stimulation, clomiphene citrate or letrozole, it is recommended. How ovarian stimulation is done? It is done clomiphene citrate and letrozole, they are advised to be taken from 3rd day of cycle and continue for 5 days. Doses are increased in monthly cycles for 3 to 6 months, and in each cycle intrauterine insemination can be done. IUI could be considered with ovarian for stage 3 to 4 endometriosis. IUI could be considered with ovarian stimulation, means it can also be considered. Otherwise IVF is recommended for stage 3 to 4 endometriosis, and ICSI is beneficial if there is concurrent male factor infertility. Okay, so these are the recommendations for ART after surgery. This is the procedure of IUI. The semen is collected in a sterile bottle and it is injected from the through the cervix into the uterus of the patient by using a sterile needle, and at the time of ovulation, and then the fusion of sperm and egg, it occurs in the fallopian tube, and the natural process of fertility is observed in IUI. And before performing IUI, ovarian stimulation has to be done. Women can be reassured that recurrence risk will not increase following ART. Okay, so very important point, that whether there is any chance of recurrence after artificial reproductive techniques. So no, answer is no. In women with endometriomas, clinicians should use antibiotic prophylaxis at time of oocyte retrieval, although risk of abscess formation is low. So antibiotic has to be used. There is insufficient evidence regarding extended administration of GnRH analogs, COCs, progestogens to increase live birth rate and positive pregnancy outcome. Okay, so clinicians are not advised to routinely perform surgery for a stage 1 to 2 endometriosis and ovarian endometriomas to improve fertility, as it could have negative impact on ovarian reserve. So, very important thing, that not in all cases of endometriosis we have to perform surgery to improve the fertility rate. She can be placed on conservative treatment and medical therapies to conceive. However, surgery can be performed for endometriosis associated pain and accessibility of follicles. So, if, because of adhesions, there is difficulty to access the follicles for artificial reproductive techniques, then the surgery is advised. Surgical excision of deep endometriosis is primarily done for pain relief rather than infertility. Okay, so if endometriosis is present on bowel loops, on rectum, sigmoid colon, or it is involving bladder or ureters, and it is diagnosed, then surgery is only advised for pain relief rather than infertility. So thank you so much for my today's lecture. In next lecture, we will be discussing fertility preservation for endometriosis. Thank you.